This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
I am a board-certified family practice physician who started my DPC journey just 1 year ago, February 1st, 2023. And so far, I'm loving it. My backstory is I did lots of years in the insurance model. I spent 16 years in Florida doing Medicare Advantage and all of the fun that goes with that. We moved back to Pennsylvania and decided that that was no longer serving our family and that was no longer for us. So we jumped into direct primary care after researching it for about 7 years. And I have to say, working with my family, working with my husband and my mother and my sister has been amazing. So I'm Amy Capoocia, and this is my DPC story.
Dr. Amy Capoocia is board certified in family medicine and osteopathic manipulative treatment. She is trained in all aspects of family medicine, from infant and child care to women's health, general adult medicine, geriatrics, and dermatology. As an osteopathic physician, Dr. Capoocia embraces the body's innate ability to heal itself through proper nutrition, exercise, and aligning the mind, body, and spirit. Dr. Capoocia earned her doctorate of osteopathic medicine in 2003 from the University of New England College of Osteopathic Medicine, then her fellowship designation in family medicine through ACOFP in 2015, and a second fellowship in health policy in 2018. She has taught lectures for the American College of Osteopathic Family Physicians, including instruction in wound care, dermatology, joint injection, and osteopathic manipulative treatment. She continues to lecture for the Direct Primary Care Alliance and other state and national conferences. Dr. Capoocia also believes in giving back to her profession through teaching medical students, hosting community lectures, and working at local free clinics. Dr. Capoocia, most importantly, is a wife and a mother to 5 amazing children. She puts the family in family practice. Welcome to the podcast, Dr. Capoocia.
Thank you for having me. I'm super excited. So I'm glad that I got to meet you a few months ago. This was, you're my dream, my inspiration.
Oh my goodness. It was such an amazing thing to see you again, not only in person, because, you had done presentations for DPC online during the pandemic, but to see you in person and then hear that you had just opened. I was like, I thought she's been practicing for years. So I am so glad to have you share your story. And what you shared a nice teaser in your intro about your journey and your 7-year research stint in thinking about DPC, planning DPC, and then finally doing it. Congratulations on achieving your 1-year anniversary in DPC. That is amazing.
Thank you. I very much appreciate it. I have been a stalker for years. I knew that doing the HMO model was a little bit soul crushing and it was not where I wanted to be, but the money was good. And I just couldn't keep my heart in medicine any longer if I had just kept serving the money and serving the industry.
So let's go there because I have conversations with people all the time who are in fee for service or they're residents who are like, I didn't know DPC was an option. I've already signed on my contract to work at said insurance-based clinic. But I want to ask you, when the money's on the table like that, what was it that made you start changing? I mean, I know you had researched DPC for 7 years, but
Mhm.
what was it that really, that really said, I am not going to be able to take the money as my reward for doing this care that I don't feel is speaking to my call to medicine that I had when I applied to medical school?
When I was in high school, when I was younger and growing up, we had a small town family doc. He ran Twin Valley Medical Center. We went there for everything. They did x-rays, they did labs. We hadn't, at that point in time, had the insurance creep in so much that you couldn't get things done at your primary care office. What I saw was that creep started to come in a little bit when I got into college. I'd go home and they'd be like, oh, sorry, you have to go get your x-ray somewhere else. They no longer pay for the x-ray to be done here. So my understanding of family medicine was that I was supposed to do everything, that I was supposed to take care of every illness, every sickness, and then just call on my specialist buddies here and there if I needed it. But not that I was going to send my patients out for dermatology, send them all out for routine stress tests, send them to the rheumatologist for mild arthritis. It became so piecemeal in my early years. So I went from residency right into a practice where I opened a practice affiliated with the hospital. And then my husband said, you know what? Wouldn't it be really nice if we went somewhere warm? So he was originally from California. He grew up in San Diego. I said, okay. He went to Maine with me for med school. And then he went to Pennsylvania for the last 2 years of med school, internship, residency, and then my first few years in practice. So it was my time to give. So then we found a job, got a recruiter, went down to Florida that first year. It was here, join me, eat what you kill. We're gonna be a group of 2 docs, 1 nurse practitioner. That ended terribly. So there was no HR. It was just me working for him and working 5 in the morning to 5 at night on Saturdays, rounding on patients, submitting my claims, being told, nope, you didn't make enough to pay your salary yet. Nope, you didn't make the bonuses yet. No, you can't see the paperwork. No, you can't see that. So I did that for a little bit and then took a stint back to Pennsylvania for a year. Housing market crashed. We were renting up here, still paying on a house in Florida, then said, okay, go back to where you live in the house you own. So moved back to Florida. And at that time, I found a much better job. And that was that was my first foray into the HMO world of being a physician working for Medicare Advantage. The first docs I worked with, initially, it was great. We worked with just one insurer. I knew exactly what was expected of me. But then we started growing really fast. And by the end of 5 years, we were outpacing what we could reasonably accomplish. And then the weekly meetings became more of, hey, how are we getting our MRA codes? Hey, are we hitting our bonuses? Hey, are the money, the code, the money, the code, the code, the code. Are you hitting all your end of year marks? Is their blood pressure under 140/90 December 31st, or we're out of compliance? So it became just very compliance driven, very code driven, very much that I felt I was spending more time with my chart than I was with my patient, and data mining to get reimbursed. The beautiful thing about it, the really nice thing about it, is I think we did it very well and better than a lot of the other docs in the area. But we were a full capitated risk. And not many docs know what that is, but that means that the insurance company paid us directly to keep the patients healthy, well, out of the hospital. The healthier the patients remained, the less hospital visits they remained, the more bonuses we got. And I think that can work beautifully. And I think we were very ethical, at least when I was there. And I just saw, though, that a lot of other places were not ethical and patients were getting diagnoses and never being told of their diagnoses. And so it just starts to creep in the back of your head of, are we really doing what we were supposed to be doing? And then I went to another practice. As that one, there was just some personnel changes that didn't work very well for me and my family. And then I went to another practice that was another HMO, and it was more of the same. And the weekly meetings then just still end up not necessarily being patient driven, patient care. It's not like, what are we doing for the best of the patient? Can we take these bonuses, roll it back into the patients? Maybe we can buy our own CAT scanner. Maybe we can buy our own MRI. It wasn't any of that. It was just, how can we just keep growing and expanding? And how can we have all of these people employed and cut all the corners we can and still keep just adding patients to your panel? So when I left, I had a 3,000 patient panel, and they were very sick patients. And it just was not attainable that you could go in the beginning of the day and leave at the end of the day and think that you caught everything.
And not only catching everything, but in terms of your scope of practice, did your scope of practice change when your panel continued to grow and grow?
So what happened there is then I became supervisor to 5 mid-levels. So I was the only physician for the 300 or 3,000 patients. I had a lot of nurse practitioners and PAs, but they were just right out of school. So you're trying to supervise someone who has not done a residency, who has not had supervised care. Some of it was during COVID, so they really had no supervision. And so basically, I'm trying to run a residency in my office. I'm trying to see every patient that the nurse practitioners or PAs have seen. So that leaves me about 5 minutes to kind of walk in and be like, hey, I'm Dr. Capoocia. How you doing? And let me just get the rundown real quick. Let me quick listen to your heart and lungs and look at your feet and ankles. Make sure you're not swollen. Okay. This is what I think the rash is. What did you think the rash is? I would try to sit down so at least they felt like I had given them more time. I mean, I've listened to all of how can you make your patient feel like they're more valued in a short period of time? So I'm sure you've heard of those seminars too, where it's, if you sit down, if you lean in, if you do all these personal touch things, your patient will feel valued. And I wanted my patient just to know they were valued and not have to do these little quirky things to really make them feel like I was listening. So it was just very dissatisfying at the end of the day.
I totally hear you when you talk about how, there are strategies. Sure, there's also solutions to actually taking good care of your patients, which you're doing now, thankfully, as a DPC doctor. So when you were in this place of, wow, this is definitely not what I signed up to do, tell us about your transition, because given that you had experiences in many clinics as to how things were run, why did you choose DPC after those 7 years of researching and thinking about DPC versus another model, like building your own clinic and limiting the number of patients you had under the fee-for-service model?
So when I was doing the HMO model, and then I heard about DPC, I was like, oh, I'm basically doing a DPC model here. I'm doing the joint injections in the office. I'm doing their dermatology. I'm trying not to refer them out. I'm trying not to do X, Y, and Z. But then at the end of the day, you have this huge Medicare sheet that you have to click and check. And then you have to do all the compliance and all of the HEDIS and STARS measures and all. It was just, I think, measure burnout. And I thought about it. I was like, I am amazing at this. I am like a type A. I will be a top performer. I will get 98% and higher on my patient satisfaction scores. I mean, everything on paper looked amazing, looked great. But I was just like, I don't know if I can do this. And I did look into it. I honestly did. I said, okay, I know this direct primary care thing, but it still was not in my comfort zone financially, because I was probably better reimbursed in Florida than most family practice doctors. I was very good at what I did. And I do believe that we as a whole in our group gave our patients amazing care. Like our goal wasn't necessarily to bilk the system or anything like that, but I just didn't like that at the end of the day, things would creep into my mind about how can I upcode this chart? How can I make sure we're getting enough revenue to cover if the patient does have a hospitalization in the ICU for COVID, do I bring in enough? Because that's scary. So we were paying the bills. So you always wanted to make sure you had extra revenue. So you're like, well, am I really upcoding, or am I just being wise and making sure that they have atherosclerosis of the aorta, I coded that. If they have DISH, I coded that. If they have diabetes with retinopathy, I coded that. And that's all. None of them were our wrong codes. But the fact that you're like, some of my charts had 20 to 30 codes on them. And twice every 6 months, you're like going through inventorying every code, making sure you talked about it with the patient, make sure you said something about it for the patient. And I never felt like it was necessarily the patient driving their care. It was me kind of saying, so this is what we have to do. And do you have any concerns at the end? So then when I came up here, I did look into in Maryland, they have some of the HMOs similar to what we did in Florida. Pennsylvania really hasn't gotten on board with that yet. I'm sure it's coming. Florida was advanced. They had the HMOs for 30 years. So they were the great experiment. It's kind of worked as far as anything in Medicare has worked to contain costs and get patient good care and make sure they're assigned to a primary care. But the more I thought about it, I mean, I called people, I got set up with insurance reps. And I was really like, okay, I could just do this and not have to take a pay cut. But then it just didn't feel right to me. It just wasn't, I couldn't see myself doing that for another 10 or 15 years.
And as the listeners heard in your bio, you're a mom of 5. So can you
Mm-hmm.
give us a screenshot as to what life looked like as a mom when you were making this transition, as you were practicing in Florida and then going into Pennsylvania? What was life like on the family side of things?
You do the best you can with the little bit, a couple hours a day you have with your kids. I feel like since I've made this transition, I am a much better parent. I'm much more present. My kids did not know that I knew how to cook. So I think it was just like a week or two ago. They're like, "Oh, you never really cooked before. We just thought you could only make pancakes, eggs, and French toast." Wow, that's true. I am cooking so many more meals since I've switched to direct primary care. I am not screaming as much as I was. There was one time when my kids were little, and it was just a check for me. That was the first job that I had, and I had 3 little ones. One was 3 years old, one was 2 years old, and one was only a couple weeks old. And somewhere in that next year, that first job that I had that I said was just terrible. That was the eat what you kill job, and that was your true fee for service. You took every insurance, and you're just supposed to kill yourself and hope it works. I mean, I was rounding at 4:30 in the morning, and sometimes my husband would bring the kids in at lunch, and then I go into the hospital on the way back because we did full scope. We did hospital, we did nursing home. And then I'd see the kids. I'd make sure that while they were awake, I was there not doing anything. But then they'd go to bed at 8 or 8:30, and then I'd be charting until like midnight. So I lost my temper one day, and I was just like, oh my gosh, I'm going to start being mommy dearest. I can't. That was the turning point for the first job was like, I cannot. One, I'll end up on the news. That'll be terrible. But 2, this is not the mother that my children need. There's no reason to have kids if I'm going to be this crazy. Yeah, I was just so sleep deprived. It was awful.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. If you're not familiar with Mommy Dearest, Google "no more wire hangers" and you will know exactly.
That's what I felt. I was pulling clothes out of their closet and I was like, this is not clean. I was like, oh my word, who am I? I called my husband. I was like, you should come in and take care of the kids. I just need a nap. And that was, I think, the last time. Ever since then, that's made me very aware of my reaction and you have to get sleep. You can't go on 4 hours of sleep and small children and do this. So that's just not, but that was the old school medicine way too, though, was like you round in the morning, you work really hard, you go see your patients in the evening, and that's what they deserve. And the divorce rate's super high. And I was like, okay, well, I know my boss at that time, then after a year of working there, he was already on his way to getting divorced. I was like, I'm not a nice person. This isn't for me. You can't be everything to everybody. So that was my very first, you can't be everything to everyone. You have to pick what you want to do. And then through my jobs, again, it's really still hard when you go through residency to not, I mean, we're trained that you need to be everything to everybody. That You are a physician. You've been given this gift. You should not squander it by ever saying no to whatever anyone asks of you. You should be on every committee. You should do all the things. You've got to be a good and be a great mom too. I'm super lucky my husband was able to stay home. So he's not in medicine, he's in accounting. So he gave up his career so we could have a family. Otherwise, I would not have had 5 kids if I didn't have that support system at home. You can't leave that early in the morning and, you know, expect some stranger to come into your house, take care of them.
Definitely not easily. And you're so right. I know that there's listeners out there who are probably in tears because that expectation still continues to this day of you have to be all of the things. And with whatever hours they're on the day, I don't know if people are familiar with that show where Evie was able to point her fingers together and freeze time back in the 80s. I wish that all the time, even in DPC, but
Right.
how could we do all of those things that we did before? Of course, burnout was going to be inevitable. And I'm sure, again, there's listeners out there who are finding probably some relief that it's okay to not do all of those things. And so there, I want to ask about you then, deciding to open your own direct primary care clinic. When you talk about having attended lectures and whatnot about how to make the patient feel that they're valued or make the patient feel they're being listened to, did you also have any entrepreneurship or business aspects to your training or to your onboarding when you were at any of these clinics that you could have brought to direct primary care?
Actually, I did. I have never not had some involvement in running my practices. So even though I wasn't the owner, I was still one of the managing partners in the practice. So I was not paid partner, but for my very first job, I had an assigned a satellite clinic, and that was my job to just bring it up to snuff, take it over from somebody who didn't do a great job with it. So I learned the books a lot, and I was very privy to some of the billing and coding side of it. And then every other job, I was running an office of some sort. So the last job I was in Florida, I was the lead physician there. So I had access to all the way that the HMOs worked. And I had access to HR, and I was involved in hiring and firing. I didn't have to be, but it was one of those things I was like, well, this is my office. Even if I don't own it, I always felt very big ownership in any practice that I was in. And that's just my personality. So I was seeking out things, and people were willing to tell me to a degree about the financials and about what tools they use for hiring, what tools they use for firing. It's still not the same as starting your own LLC. And then, I mean, even just figuring out, do I do an LLC? Do I do an S Corp? What is that? How do you learn these things? I don't have an MBA. Would I have learned that with an MBA anyway? So I know you've interviewed Dr. Una before. So I had a friend of mine does sports medicine in Massachusetts, and she said, listen to Dr. Una, just do a crash course for an MBA. And I always sit there, I'm like, someday maybe I'll join. Who knows? I just don't know how big I want to get. So right now I'm happy and small, but I've always grown things. So who knows? So I did a lot of crash courses on that. I think I listened to Bootstrap MD. Whatever medical podcasts were out there and people recommended them, I listened to it, and I became someone who loves podcasts, which was not me before. I was like, okay, I need to figure out. And part of my decision making, I almost bought a practice. So I came back to Pennsylvania, and my very first doc, he said, my friend is older and he's got this practice and he would love for you to join him. And so I did, because I'm that good girl. This is great. I'll just trust you. And he wasn't wrong, but it just was not a good fit. They still had paper charts. The practice was 40 years old. So it really would have had to been brought up. I think there was just like way too many outstanding bills that were basically essentially now became loans. So it financially did not make any sense. Anytime you buy somebody's baby, if they start this practice, they own it for 40 plus years. They're going to want some value for it. And I just didn't feel like it was worth the value that the other physician had wanted. So it was really tough to walk away, because it would have been really cool to have a legacy practice, but it just would have been a ton of work. and it still would have been fee for service. And then I would have been having to get them up to par with an EMR and all the other insurance brokers, and their billing and coding wasn't, I could tell they were losing revenue just by looking at the notes going, oh gosh, there's no way you're getting paid for the amount of time you just spent with that person. I know you just spent a half hour with that person and your note is basically 5 minutes worth of, So I would just assume, I said, they would have just taken too much. And a big hesitancy of starting a DPC was just getting your whole family on board. I'm the sole breadwinner for a family of 7. I have kids in college. I have a 17-year-old who's looking into colleges. So trying to sit there and go, okay, we're going to just put everything we have in reserve into this. We didn't take out a loan. We decided we were going to loan ourselves the money, put it into our account, and then draw off that. And thankfully we'd sold a home in Florida at the best time. So it took us 16 years to get our return investment, but finally it was our time. And then we saw the writing on the wall and said, okay, we tried to move 16 years ago and the market crashed, and that wasn't for us. With COVID, my dad had gotten really sick. So he had gotten AFib, he had a PE. He's doing great now. And if you ask him about COVID, he's like, that was fine. It didn't really affect me. I'm like, really? But with all the restrictions, I said, I don't want to be 1,000 miles away from my family if something goes wrong and I can't just hop on a plane and I can't take a week and a half off just to drive. So that was finally, my husband said that he was ready to move up. So, and that's a big deal. He's not used to freezing cold. So when he said, I really want to move to Pennsylvania, I was like, I'm going to take this chance and we're going to do it. And then he said, but I don't want to do the direct primary care thing yet. I don't think we're ready yet. Maybe you can do 2 years of being a hospitalist or 2 years of working urgent care or 2 years of whatever. So I looked into a million different scenarios, just like everybody does when they're changing jobs or changing locations. Had some doozies of stories for another podcast, another day. And there's just some red flag things going on. But in the end, I ended up where I'm supposed to be. So he finally, after the red flags and the conflicts and all that, finally got him to a point where he said, you know what, I feel confident that you are the one to run the practice. And I think that you're going to do great. And so having his support was amazing to hear your spouse say, yeah, I definitely think you're going to be great at this. You're going to be good at this. And I just want to be there to support you. That to me was just, I better do this before he changes his mind.
Especially coming from a place where you shared how you were up so early in the morning, how you treasured the couple of hours you could spend with the kids, and to go into a new venture that you had been looking at, but your husband wasn't necessarily looking at the same level as you, to go in with family support behind the decision it's huge. I definitely appreciate that from a spousal level, in terms of my husband definitely supported me when I opened my practice. And I think that's really important to have those conversations. Like, we've heard about this from many guests, Dr. Jade Norris, Dr. Amy Ostick, multiple physicians who have talked about how their spouse and them had conversations about DPC is on my plan. So how do you feel about it? And I think it's really important. And one of those things that I loved hearing from somebody, I can't remember exactly, I know Dr. Jade Norris had talked about it, but I can't remember who else I'm thinking about. They had their spouse listen to these podcasts, and it can provide some reassurance that DPC is possible in all areas of this country. And going into now, your clinic was decided on, you guys decided on the DPC model. I want to ask about how you envisioned your clinic, because clearly you valued being a full scope family physician. You're an osteopathic doctor. So being able to practice in a place where you could bring all of your skills to the table without anyone telling you what you could or could not do anymore, and not having to worry about the codes. What did you envision your practice to be before opening your doors? Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
So with the HMOs, it was similar. I did get to practice full scope. So I did get to do the joint injections and the dermatology and all those things. So that was definitely a bonus for me that not every other physician in family medicine has. We were scheduled, if I was allowed to say Friday's my procedure day, and no one took that away from me. I was waiting. I just kept feeling like somebody's going to try to take this little nugget away, but I was allowed to have Friday procedure day. So kudos to my bosses that they did see that. I mean, again, they were working within the same system. So what was wrong with the system isn't what was wrong with my employers, but it was great that I could still do that. So I knew that's what I wanted to continue. And I've also had the pleasure of teaching for the ACOFP on their procedural medicine committee. So if I didn't know a procedure, I asked my buddies who did things. I would love to say that I'm great with ultrasound point of care, but that has eluded me. I just can't get my creative vision in the ultrasound yet. So maybe another day. I'm going to have to do a week-long course because the short course is just, I'm not there yet. But I feel like my palpation skills are good. I'm an osteopath, so I old school practice. I went to University of New England. We're like so granola up there. We had weekend cranial courses. We had every Tuesday, Thursday, we had hands-on classes. So, I mean, you have this whole other 10,000 hours of more training and a lot of elective if you wanted it. So I went to the Cranial Academy courses. I went to some of the courses out in Colorado. I feel like my palpation skills are good, and I might be more confident than I should be, but I feel like I've never been afraid to stick a needle in anything I love surgery. I love dermatology. I love cutting things and sewing them back together and making them look pretty. So that has never been a fear of mine. Phlebotomy was the hardest. That was so frustrating and humbling. Very humbling. I'm like, I see the vein. I feel the vein. Why, when I stick the needle where this vein, is it not giving me a return on my investment? Like when everybody say, oh, my veins roll, but I honestly did not believe them. I was like, they're veins. They don't have big muscle walls. Some of those are really cord. I was shocked. So kudos to my phlebotomist. I've done some TikTok videos and I always wanted to be like, hey, this is what's great about medicine, because I'm so tired of what's terrible about medicine. There's still a lot of amazing stuff about medicine. So my highest yielding TikTok was when I was like, thank you, phlebotomist. But it's true. I had to call my friends who are phlebotomists and be like, how are you the vein whisperer? How did you get everybody? And some of it is just confidence to go deeper. And some of it's using the little teeny tiny butterflies and letting the return show. Yeah. But that to me was the hardest thing. And I think it's good to be humble every once in a while to be like, oh, you think you can do surgery. You can't stick this needle in a vein. So it was good. It was good.
When we can do all of these things and then to our own bodies, we're like, I don't do needles well. I was more fearful of having an IV than a baby until I had a baby. And then it was like, okay, yeah, no, I really thought
stick whatever you
was,
want in there.
Yeah. But let me ask you there, because with you having been a patient in a model where you saw your town doctor when you were growing up provide full scope medicine and provide excellent access to care, when you decided to offer phlebotomy at your clinic, tell us about the decision to offer phlebotomy versus outsourcing to a national lab or someone else who could do phlebotomy for your patients. And how did you start learning those skills to be able to do phlebotomy as an offering at your clinic?
I have just always loved the idea that if someone was sick, they didn't have to travel anywhere else to get labs. So in my practices in Florida, all of our MAs drew labs, and we had an LPN and we had a nurse who would do IVs. So we weren't in urgent care or anything, but we did a lot of urgent treatments, and we did IV fluids. We gave iron infusions, we gave Prolia, testosterone. So I really wanted to emulate what had worked really well at my old clinics. And the only way, without having to hire someone else, because you're just starting out and you're like, is this really just a pipe dream and it's not going to work? And I don't want to sink too much money into it or sink someone else's life into this if I don't, if the people in my community aren't ready for this. So I just knew that was an offering that my patients found incredibly valuable. So that my whole goal is trying to provide as much patient-driven value that I can. So if I don't have to send them out, I live 20, 30 minutes away from a lab. It's not like there's a lab right around the corner. So if I'm ordering their lab, it's fine for my patients who live 40 minutes away and they're like, oh, there's a lab by my house and I'll go fasting. Like for them, it doesn't make sense to drive down here fasting and get their labs done. But if they're here and they're sick, it's amazing to be able to say, yeah, you're sick. I'm not sending you anywhere else. We're going to do these. I'll get the results for you by tomorrow morning. We're going to do X, Y, and Z, and then we'll follow up by 8 a.m. They love it. And I love it. I like having control too. So I like being able to say, I know that when I order this lab, it's going to be done now. I'm not going to wait. And the patient's going to be like, I don't think I really need this lab. I'm going to go get it done in 3 months. So it's just great.
I also give you props because when you were speaking about that, you were working in clinics that weren't focused on the patient and were focused on the business and the codes and the business and the codes. I mean, I love that you talked about that you wanted to bring the biggest value to your patients by doing things like offering them Flebo. And I think that really speaks to how much the people who are doing DPC love DPC because we're able to do these things because it makes a difference for our patients. So with you having shared about what you envision for your practice and how you're bringing things like phlebotomy into your practice, can you give the listeners a little bit of a visual walkthrough of your clinic and how it's situated?
Sure. So I have the cutest little clinic and we just happened upon it. I said to my husband, I said, if we could find a clinic or a little office in Ludwig's Village, which is this little corner, it has like an 1800s history to it. And then it just got built up around it. I said, that would be the ideal because it's right where rural meets suburban. So to my left is all cornfields and there's a meat, I call it the meat farm because I don't eat meat, but they grow cows for people who like to eat meat. But you can get your fresh farm-raised meat and chickens and eggs and all that stuff is on this side. And to the right is high-rise apartments. So it's a very interesting juxtaposition of Philadelphia comes out to, he was like, I want to move to the country. I'm like, no, you don't. You think you want to move to the country, but you wanted to bring it all with you. So this I knew was going to be an ideal location. Plus my very first job where I got a paycheck was at the gas station across the street. So it was Sunoco gas station back then, and we made subs and we pumped gas. So that was my first job, and I thought it was really cool to be able to come back here. So there was nothing available. We looked online. There was nothing available. My husband just happened to drive by and he saw that they were unloading boxes from this medical practice. And he said, hey, I think this practice might be open. It looks like they're moving somebody out, but there's nothing listed. There's nothing posted. I'm just going to go introduce myself. So he walked in and basically said, hey, what do are you renting this? It wasn't rented. The doctor had just kind of stopped showing up to the office. I don't know whether they got sick or it sounded like they got sick. And so they didn't really know what to do with the office. And they were just like, hey, great. It's been basically vacant for 6 months. So it's yours at the end of January 1st if you want it. And this was like right around Christmas. So that's when we were like, all right, we're all in. So from Thanksgiving to February 1st, that's what we made our decision the week of Thanksgiving that I wasn't going to buy the other practice. And we kind of just crammed in Rocket Lawyer stuff, read all like the legal papers. What do we need to do? Thank God for the DPC community though, because how else could you learn something in 8 weeks? I had your podcast I could listen to. I had a couple of other podcasts. I'm drawing a blank on her name right now, but I think Pam Wibble. She has a whole bunch of things about starting your own practice and just being confident. So she's like this great cheerleader that when I was like, I can't do it. I just put on her podcast and she's like, you can do this. Yes, you can. I was like, all right. I've never met you, but if you say it, then it must be so. So I just listened to a lot of positive things, talked to my friends who had already run or already had their own businesses. They weren't necessarily DPC, but they were just like, yeah, you can do this. If I can do it, you can do it. We all can do this. We went to med school. That was hard. this is not as hard as med school. If you survived anatomy, you can learn how to run a business. You just have to like put your nose to a book or two and you get this. And I think the biggest thing I learned about starting DPC is know what your strengths and weaknesses are. If you're not the money person, maybe you do have to hire the money person. Like it's okay to not be good at all the things because we need to be good at the back of the office stuff and making sure we order the right supplies and networking with the right people. We don't have to be good at all of the billing and all, where we did in fee for service, you had to be the biller and the coder and all of the things. It's okay to now not be all the things. And I love it. And the location is great. So back to your original question, which was, what does my practice look like? You walk in the door, there's a tiny little waiting room. There's 2 chairs in it. And then there's a little kid table and a little kid antique old chair, just adorable. And everyone gave me the furniture for free. So my community found out, my parents' church found out, my sister's friends who are nutritionists found out, and they just said, hey, I have this. Hey, you have this. Hey, I really want to see you succeed. That's amazing. Here, let me give you this. That was awesome. I never expected that. I think that's the other thing you need to do is just ask. I think I put out there, does anybody have any little kid chairs? Bam, there it was for free. And it was great. And then Craigslist for other stuff. But if you walk in, so I have that cute little setup there, and then you come down, it's all off one central hallway. You come down and there's the reception on the left, and then there's a little closet, but it's got a desk in it. So it's just like a corridor from the reception area to the hallway, but that's where I sit, is in the closet. That's all I need. And then you go down, we have our lab on the right. So I have a lab draw chair. So I think it's really a Jerry chair. So I draw labs on it, but if they pass out, it's fantastic because then you just flip the feet up and they're safe. And it's only the 6'4" guys that pass out. So, and then you go down the hallway again, I have the room that we're in now. And then I have a little kid room where I have it all set up and it's got little cute things on the walls and it's got a diaper changing table instead of an exam table. So all the little kids go in there and basically from 4 and up come in here. I just use an OMT treatment table, which is like a massage table. And that's what I've used for everything. Eventually I'll get a big girl exam table. But this has worked great. And I do PAPs on this and I don't use stirrups. Somebody else in DPC was like, listen, the pelvic floor PTs don't use stirrups. Why do we do this? And I was like, oh my gosh, I just got the bolster. You put it under the hips and you do the PAP and everybody loves it. It's amazing.
I love that. And I think that's important for people to hear too, because you can get a massage table. It's not necessarily an OMT table, but you can get a massage table for $82 on Amazon. And I've said this before, but if you have a DPC in the works, or if you have equipment that you're like, oh, I really want to get something, but I can't get it right now at that price point, put it on. I have a list on my iPhone that is a Black Friday list. So literally I put links to things and then on Black Friday, I'm like, ding, ding. And then that's how I have a like stadiometer, one of those wireless ones that I got for 60% off. And I was like, I'm much happier now with my stadiometer that I paid 60% less for. And yeah, I mean, when it comes to what patients are expecting in a DPC practice, they don't even see I mean, clearly you want to make a nice, safe space for your patients, but they're not going to see, wow, these are mismatching chairs. They're going to see, it's Dr. Capoocia. I love Dr. Capoocia because she actually spends the time with me. Like, I feel like I'm the person who she is doing this practice for, not the codes. And no matter where you are, people understand that frustration of, well, that's just how it is at that clinic because that's how you go through, like you're a cat or you're a piece of cattle or whatever. But so I just love that that's how you're doing it. And I remember you said that at the summit when you were giving your lecture about how like you use your OMT table. And I'm like, amazing. And when it comes to the bolster, a bolster is not expensive. I definitely, even with stirrups, because I have a table with stirrups and I still have issues sometimes, but I have people rest their fists under their buttocks and just that little tilt. Same thing as a bolster, like it really makes a difference. But there's things like that people, like you mentioned on the DPC communities, they'll be like, have you tried this? Or this might be a way to get the same thing done without spending gazillions of dollars. So I love that. Now, tell us about when your husband went in and introduced himself to the people in the clinic and it worked out that you guys could take over the space. Was there an option to buy the clinic versus to rent the clinic? And if so, what was the reason for the decision you made to rent or buy?
So one of the major reasons we didn't buy was because when we decided to move up here, we purchased my sister's home and then did an extensive renovation. So we already have a big mortgage. So, okay. And now we live in the house and we're like, now all the kids are moving out. Now it's too big. So maybe we'll downsize in a couple of years and then maybe we'll buy our own practice. But yeah, there is not an option to buy at this point in time. We do kind of like whisper in their ear, like, hey, maybe in the next couple of years, if you guys are getting older and you want to sell, let us know. But the feel of this office is amazing. So I don't know if you can tell, it's got some wainscoting on it. So there's some beadboard. It was initially this color green, this lime green. It was a psychiatrist's office. So I don't know how that worked. Yeah. So to me, that was not the best choice. It's not very relaxing, the lime green all over everywhere that you see the blue. So all the paneling was lime green. The front entry was lime green. The fire, there's an adorable fireplace in our waiting room. That was lime green. So we toned it down, picked some colonial colors, some black and white accents. And I think the feeling when you walk in here, like everybody walks in there, oh my gosh, this doesn't feel like a doctor's office. And I think so much in medicine, it's gotten, as hospitals buy things, they bring the hospital aesthetic to all the private practices. So the private practice I went to when I was growing up, they had a giant fish tank in the waiting room and cozy chairs. And it was just a very welcoming, homey environment. And now I think we've gotten more and more that quote modern feel, but hospital modern, not really like someone designed it artistically modern. So this is definitely a more cozy office.
And going from the amazing green color that you described to this very soothing, very peaceful color that you have now, did you guys do the painting yourself? Did you guys do renos on your clinic to save dollars there?
The landlord was so happy to have us here that he did all the renovations himself. He took up the carpet. He put laminate, like some type of vinyl. I know I'm supposed to know the name of it, but some kind of vinyl flooring down. My sister does renovations. I should know, because that was our thought. We were like, well, we'll renovate it ourselves. I have 3 sisters who live in the area, so everybody's super handy. Not me, but everybody else is super handy. I can paint if I need to, and I learned I can cook. But they did it all. They said, we really want you there. We want you to be here for a long time. So what do you need to be up and running by February 1st? And they had it done super fast. It was amazing.
That's awesome. And it definitely speaks to a really good landlord when they do things like that. Can you also give any insights as to best practices for talking to a landlord, negotiating terms of agreements, or at least terms of lease?
So we had gone and looked at a couple of different properties. Some of the podcasts I was listening to, they're like, you just need a stethoscope. And they're right. You just need your bag. You don't need anything fancy. I didn't need this. But I wanted to be here for a long time. And I didn't want to like go into one place and move in a year. And I looked at some places and they were just not nice. I could see the vision for here. I could see past the color and go, the feel, this community, it already is a community center here. So if you say Ludwig's Village, people in the area, they know where that is. So they're like, oh, Ludwig's Village. Oh, and I heard somebody say the other day, actually it was probably on Facebook, because I learned all the free marketing tips on joining every Facebook community page. And I've gotten so much more return on the free marketing than on any paid marketing I've done. So we can come back to that. But so on one of the Facebook marketing pages, they're like, somebody said, oh, Ludwig's Village Family Medicine. Has anybody heard of this? And they said, well, it's in Ludwig's Village, so it's got to be good. I was like, okay, so where you put your practice does matter. I was going to go up the road and it was going to be in the back of this community center, but it's not really a community center. It just has a bunch of stores and shops, and it didn't really have a vibe to it. And it was going to be half the price, but there was still going to be a build out. We were going to have to pay for the build out. It still would never, ever have the flow of something that was built to be a medical center. This was already built out with the intention. At one point in time, it was a dentist's office too. So it was always built to provide care to people. So it already had the flow, and I wasn't going to have to create it. So we looked at a few different places, and none of them, you have to worry about handicap access. I live outside Philadelphia. So Chester County has a lot of stone buildings, a lot of like non-ADA compliant things. They're super cute buildings, but you have to look at the building and go, can a wheelchair get in here? If someone throws their back out, I don't have an elevator, can they walk up the stairs to the second floor? Like all those things that I just wanted the best convenience for my patients, the best, um, they can park and just walk right in. So there's a little ramp. So the ease of use of the office space was really important to me. And this had the best ease of use, had the most cozy feel, had the most inviting environment around it. And I knew what my price point was going to be. And we started low because, of course, when you start that first year, and this is what I would recommend, this is what I did. I started at a lower price than what I wanted to eventually get to because I was like, this is a startup. I don't have an EMR. I kind of don't have full office hours. I was still working part-time at the other one where I turned in my notice. So I felt they're giving me a chance. I have to give them something in return. I have to give them a discount. And they're like, wow, you provide all this for this fee? I'm like, yep. And then 6 months into it, we decided, okay, we've got it locked down now. We've gotten all our supplies. You know, we're not using like borrowed stuff anymore. Then that's when we put out a thing saying, okay, if your friends and family want to join us, tell them they can come in at the entry rate for this month. So create interest, as my sister says, yeah, create interest. So for two things, it created interest and it also let people know that, yes, we are now fully functioning. We now have an electronic medical record. We're not going to be like giving you janky notes on like faux prescription pads where I just typed up my address and printed it out. So you do what you can. And the other thing I recommend is start imperfectly. Just start. You don't have to have everything built out. You don't have to have everything done. Your patients will, they might even think it's kind of cool. Our first patients, they talk about like the first couple of months that we were open and they think it's hysterical. They're like, that was so great. It was so fun.
Totally. It's ironic that we're talking about this. And it's also ironic that your clinic used to be a dental office. My husband and I we're literally in the throes of escrow right now on a building that is right now a
Yay.
dentist office. Yeah. And this idea that you don't have to have it finished from day one. I mean, literally, people have known this office that we're buying since 91 as a dentist office. And I know that there is one room that has a chair, that has a door. So we're good to go on day one, and it has working
Yeah.
heating and air system. Like my patients, I'm sure the same for yours. They're like, "Oh, what are you going to put there?" And I mean, it makes it
Yeah.
even more like they're part of the practice. So I love that starting imperfectly is a piece of advice that you just dropped there, and I think that it takes a lot of pressure off of people if they're like, "Oh, my opening day is coming up." So yeah. Now, let me give you credit also there for your patience and your growth because when you opened with 0 patients. I mean, you've shared your
Mhm.
journey to this point. You're opening a brand new clinic. And even though you had thought about pricing beforehand, you went from 0 patients to 6 months after you opened, you were up to 100
Mhm.
patients. And now you have over 200 patients. So
Mhm.
I wanted to just take a step back into pricing for a second. When you said that you had determined your pricing, how did you come to that point of like, this is what I'm going to offer from day one?
I'd love to say there was some amazing formula for it. I think we just went, if we get X, we did basic math. We said, I think in the first year, I'd like to make this. And if I could possibly get 200 patients, then we can survive if I charge this much. And then I think I just started, we ended up going up. So we started out at $70. And I think we were less for little kids. And then you started following some of the pediatric docs and things like that. I'm like, why do we charge less for kids? They're sick the most. They're always sick. I don't charge $90 for them because we offer a family rate. I know that a lot of direct primary cares don't, or they're like, everybody should be the same. It is confusing. I had so many little niches of like pricing. So, and I listened to everybody who said not to do that. And I was like, what do they know? They don't know me, right? What they don't know me. And when you only have 20 to 30 patients, it's completely fine to give everybody a different price. And you're like, this is great. So yours is a little bit higher. You're in this range. So yours is a little bit lower. You're in this range. Yours is a little bit lower. You're in this range. Yours is a little bit lower. And then once you start getting probably around the third month in, we started having a lot more phone calls, a lot more people saying this, that. And then I had to have my family members were amazing. They were like, we'll come work for you. I'll pick up 2 or 3 days a week. I'll pick up a half shift. My mom is an RN. She's retired. She's 79. And she came out of retirement to answer phones. I don't feel comfortable drawing labs or doing all that. I don't want to go get my certification again. But she knows a lot of medicine. So she's very confident on the phone. And let me tell you, having a seasoned RN and getting a prior auth done, oh man, those insurance companies don't stand a chance when she gets on the phone with them, because she sounds so nice when she does it, but you can hear the digs too. And I'm like, oh, she's good. She's much more polished than I am. So when we started getting a bunch more people joining all at one time, and then having so many different variables of this one's this pricing, this one's that pricing, it just became stupid. And it was stressing me out. It was stressing everybody. Would be like, well, Amy, what are we charging them? Amy, what are we charging this person? What are we charging that person? I'm like, okay, I have created my own frustration. So that's when I said, okay, kids are this, adults are this. That's it. We just said if they can be considered a family, even if the kids are in college, I'm fine with them still being in the family. If you got grandma and she lives like within a mile of you, she can be your family. So if someone was a dependent on the primary person paying the bill, we decided they were family. Ideally, they live at the same address.
That's how although we're changing ours because we're leaving the family plan behind in ours, and we're going to go to just straight. This is the cost if you're this age. When it comes to the whole, you just have to have the same address. Like people in our area, there's foster families where there's an adult and there's a kid, and it's cool. That's a family. Like we're not going to test your genes here. We can if you would like to be tested for cancer, but like not necessarily for membership.
Right?
So yeah. So now you talked a little bit about how you marketed to your community and how just being where you are is marketing in and of itself. But I want to ask about your typical day. What's your typical day like, given that you have 200 patients and you're not being forced to pump out those codes anymore?
Each week's a little different. We had, of course, it's right after the holiday, so it's much busier. December was like crickets, which was super nice. Oh, there's no one after 2 p.m. This is great. I can go home and wrap presents. So you're going to have the ebb and flow. Now we're having that January 1st. And doing Medicare Advantage for so long, January 1st was always hellish. So because everybody open enrolls and dumps onto your panel, and you're like, oh, I now have 500 new patients. Fantastic. So it's not that stressful. So I had a really busy day the other day with 10 whole patients. And you're like, okay, I can do this. When I look at the schedule, it looks full, but it's still just 10 patients. Like before, when I looked at the schedule and it was full at 15 to 20 minute increments, and now this is full at 30 to 60 minute increments. So the full is very different. I can get my charts done, finish them up at the end of the visit, because I still write on paper. I like paper. So doing direct primary care allows me to not stare at my computer as much. So I'll put a little bit in before I go in the room. I'll have the computer with me in the room. I'll scribble some notes on my paper that I want to make sure I put in later for more detail, just for myself. Or if I'm ordering an MRI, you still need the detail. So I'll put the detail in there that I know I'm going to need, that I might not want to forget. And then at the end of the visit, I have my laptop and I just put in whatever the diagnosis was, and it doesn't necessarily need a code because I'm not billing anyone. So I can just type it in what I want. I find I'm still just so brainwashed into getting the codes, and I have a great electronic health record, and it pops up the code if I put a word in. So why not put the code in there? And then if I ever have to go back for any reason for them to use their insurance, it's already there. So to me, that's easier. And then I'll just put in, I can order my meds, order my labs right there. Then we would go from that visit over to the lab if they need lab work, and I'll draw their labs right there. Come back, I give the lab order to my front staff, who will then set a timer for 30 minutes to spin down any of the stuff that needs to be spun. And then they'll take care of that. They'll take care of the labeling. They'll take care of the processing of the blood and send it out. And we have a Quest pickup. So that per patient, I don't order labs all the time. I have found that one of the biggest things, I live at the cusp of a couple different interesting communities. So you have the farmers and the blue collar, and then there's a community that is anthroposophic, and they do a lot of homeopathy. And so they have a different philosophy on medicine. And then there's this growing trend of, I want all of my labs ordered for everything, and I want every hormone ordered. And there is some legitimacy to that. And I think the reason they're ending up on my door is because they've been told absolutely not for so long by the establishment, that like they're totally invalidated, feeling like what they were concerned about didn't matter. So they've gone to all these alternative paths, and they've gone to all these chiropractors who are practicing functional something. I don't know if it's medicine. There's all these functional nutritionists. There's functional this, there's functional that, which to me is very different than the functional medicine movement. And I like to say the functional medicine movement just stole osteopathy because we let it go. We as DOs, we let it go, and other people picked it up and they're taking it back. So we just need to own that mind, body, spirit. And that's my approach to my patients. And I think that also shows too, is that we're allowed to entertain whatever the patient wants to entertain. And we have the time to entertain what their concerns are now. I started to fall into a little bit of trap that I was going to be everything to everyone. And I think when you have time, you're like, well, I could learn that. I could learn to be the mold expert. I could learn. And then I finally had a come to Jesus moment where I was like, stop it. You still cannot be everything to everyone. And you're going to get yourself in trouble again, because you kind of have to do years of research to be the expert. And how are you going to do that? We all did that with COVID. And I don't ever want to have to become an expert overnight again, because that was a lot of sleepless nights, a lot of cramming in, lots of articles and research. So I did finally have a talk with one of my patients, and I was like, you know what? I'm not an expert on this, actually. And I would love to help you find an expert. So I think going into direct primary care, a lot of us will take on way bigger cases than we would have before. And some of that is great and completely within our scope of family medicine and internal medicine. But some of it is maybe a little bit on the cusp of what you're comfortable with. And you just need permission to not do it. It's okay.
Awesome. And well put. And I think that it's very true that when people are like, oh, now I can do everything, they want to do lots of things that they might not have done before. And there's courses, you mentioned point of care ultrasound, like there's options for that. There's options for aesthetics. There's options for all of these things. But I definitely love the idea also of just, hey, I'm opening. So I just got to figure out like, what is my patient panel wanting, first of all, before adding more and more on. Now, let me ask you about your history of being in clinics where, especially in your HMO clinic, where you guys were down to a well-oiled machine, like you said, especially when it came to follow-ups for patients, annuals, making sure that everybody had their colonoscopy, their breast cancer screening, all of those things. How did you take those workflows and make sure that people had appropriate follow-ups, whether it be for an acute issue like a cough or whether it be for an annual exam in your practice?
Because I did it for so long, I just have my running checklist still in my head of, you need the PSA, you need colonoscopy, you need your labs. The one community is very much against doing a lot of routine screenings. Just like, why am I going to hunt this down if I'm not having a problem? Actually, two communities are. So usually that's your farmers, your blue collar workers, and the anthroposophic community is not necessarily embracing all of the potential for radiation and biopsies that they may not need. So it's trying to really blend that and just say, you know what, you're right. And I think we've reevaluated some of our routine screenings too, where it's like, you don't have to have a mammogram every year, but still do the self breast checks. And I think what I've really learned is that I can just meet my patients where they're at. That to me is the biggest gift I can give them, is to just say, that's fine. We have time to talk about this. So I don't have a deadline right now where you have to get the mammogram done. I don't have a deadline where you have to have your colonoscopy done. I don't have a deadline where your blood pressure needs to be under 140 over 90. So right now, if it's 148 over 88 or over 92, that's not stroke range. So if you want some time to cut out salt, if you want some time to get your nutrition, if you want some time to try some things that you feel like you want to try, I have time to do that. And I can be like, okay, we'll come back in a few weeks. We'll revisit this. And I know that I have the time in my schedule to bring them back in a little bit sooner, instead of saying, I can't see you for 6 months, so here's some drugs. Yeah.
You mentioned how you have an electronic medical record. When you chose your EMR, what are the things that you needed your EMR to do for your practice to fit your way of working?
So I like having my scrolling list on the side, and I like being able to type or free text in the middle, but I still need structure. So there are some out there that are very free form, no structure. I did the 30-day trial and I was like, this does not fit my personality. I want to be that person that is free form. I want to be the person I'm just going to write what I want to write, and screw them. I'm not putting the code in there because I don't have to. But when you write notes where you put 20 to 30 codes in them, you're like, okay, listen, I'm only putting 4 codes in. Fantastic. Like, whatever. I am just so ingrained with the coding part of it. It's just so part of, it's weird to say that it's comforting to me. It's sad to say, but I like having that very structured note. So ones that were less structured, even though they came with more support, maybe I could not get into the flow of doing that. I like having my SOAP format. I like being able to pick a couple different templates. I'm not a person who's really good at creating my own templates. So I'll tend to type everything out instead of create a template. And I'll type it out 400 times instead of like figuring out how to make a template. I know that's stupid and there's an easier way to do things, but I'm a really good typist. I used to scribe our lectures in med school for cash and I made a lot of money. So, because everybody else hates to type, I'm like, I got really good at just looking and typing and getting my note done. And I'm like, that to me is fine, but I like being able to know where to put my words and I like structure.
That's genius that you typed up notes for your classmates to purchase.
Mm-hmm.
We had class assignments. So every day somebody was responsible for doing the lecture notes. And so you had definitely a difference in quality when it came to,
Mm-hmm.
you knew that, oh
Yeah.
gosh, they're doing notes. You got to make sure you take your own notes this day because that
Yeah.
person's responsible. So I think that's awesome. Now, let me ask about staffing because you've mentioned how your husband is on board, your sister's on board, your mom's on board. And I love that. There's other doctors who have been on the podcast, like Dr. Cindy Jaffishi is one example where her family is like coming, showing up and helping her out. I was just thinking about this morning, Dr. Yolanda Rivera Caudil, her daughters were her marketing team and her PR team. And I just love that when the family gets
Yeah.
involved. So can you talk about how your sister and your husband and your mom, how you guys not only decided, yeah, we're going to help out, but also how they got specific roles? I mean, clearly your husband has an accounting background, but how did they assume specific roles at your clinic?
So it is very nerve-wracking to go, okay, is this really going to work? Are we going to kill each other? I adore my mother, but we are very similar. So growing up, we sometimes butted heads a lot. So I was like, oh no, like we will need very clearly defined roles. But she is happy doing the front stuff and she's happy leaving me to do the back stuff. But then it was awesome having her there with her nursing training because I had somebody pass out while I was like had a needle in their arm and she just slid it in, took care of it, threw a bucket under their face, threw their legs up. And I mean, she didn't even have to think or be told or anything like that. She just knew. So it's great that she has that background. And she has always been a very big cheerleader for me to go into medicine. She wanted to go to medical school and that just wasn't in the card she was dealt. And so she was a nurse, which is super honorable and amazing. But we grew up in a rural area. So basically she was the doctor for the neighborhood. Like, oh, I cut this. Andrea, can you patch it? Can you? So I grew up with all of that there and knew that she wouldn't be overwhelmed by all of this. So I knew she was a very good fit there. My sister who volunteered, she is like the anti-me. Like she's very low key. She's whatever needs to be done. You just give me a list. I'm going to do it. She doesn't have the desire to recreate the wheel. If you need it recreated, I'll do it. But she's like, hey, you want me to throw up a couple social media posts? I'll do it. She's like, hey, do you want to start using AI? And I'm like, terrified of AI and technology. No, why would we do that? But she has a computer science background. So she's like, I'll do this. She ran her own business for a couple years and then just like, I hate being the boss. I don't want to be the boss. I just want you to tell me what to do. So she's perfect in her role too. She's like, she learned workflow. She's come up with workflow. My mom on her own created a handbook for us because she likes having everything written down. So when I would say, hey, just do blah, 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 just do blah, 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 blah. She's, do you have that written down anywhere? And I said, I do not. I could do that. She's, I'll do that. So she was great. She did occupational med for a while too. So she's got some background in there in workflow also. So she created our handbook and my sister updated it and she keeps our username and passwords updated when I'm like, I locked myself out again. She's like, how do you keep doing this? I'm like, I'm really good at that. Like, I've never been great with computers. I don't like them. And I don't understand why after 30 days they log me out. So she's coming up with a workflow of every 3 weeks, we're going to log in, just to keep you from getting kicked out of all the health systems in the area. It's so annoying.
And even to be able to order a lark, you have to be
Yeah.
able to log in every 30 days. That's one of our workflows because we learned the hard way that if you didn't log in, then you have to go through this whole process of your account is deactivated and you just want to order a lark.
Yeah.
So
Yeah.
love that. Love that. Now, when you talk about workflows though, when even with your mom and your sister helping out, how do you guys come together to create those workflows? I know that like your mom's saying, "Oh, do you have this?" And then she writes it down.
Mhm.
But in terms of like what triggers a workflow to be made in your office, how do you guys come to the decision like this needs to be a workflow versus yeah, we do it sometimes. It doesn't necessarily need a workflow because it's not necessarily something that we have to have a protocol for.
So we started with my mom and my sister were here most of the time, and my husband was working at a golf course because that was his dream job, and he was making excellent tips over the summer. So that we had a ton of workflows, so we're now reworking it because he's come in more full time. But as we sat there and went, okay, what do you want? I did write down all. I'm like, when the patient calls, we need their phone number, their address. We can't send them any information unless we have their email. Our EMR will prompt everything, which is very nice. And we also use the feature where they can schedule online. So that's been pretty helpful. Now that we're getting busier, I've taken the meet and greets offline. So patients will have to call to set up the meet and greet because otherwise they're putting the meet and greet like right in the middle of your like 1 hour time slot. You're like, oh, I now have two 15-minute time slots before and after. So live and learn. It worked great when we weren't super busy, but now that we're getting much busier and it's January, we need bigger chunks. But we just kind of came up with, they actually were very good about asking me, like, how do you see this working? What do you want done? So they were very receptive to saying, this is your practice. And then we would sit down more often in the beginning to just say, is that working? Did that work? We came up with like just little index cards that just says in bold letters, new patient needs X, Y, and Z. And initially, before everybody got really comfortable with it, we had a paper sheet where, as they're talking on the phone, instead of typing at the same time, they were writing the patient's name down and taking all their information, especially if people were just calling to inquire about it. We'd write their name down, take their information, and then try to touch base with them in a few weeks to just say, did you have any more questions about this new practice that opened up? So even doing that paper form could be really helpful if you're starting out too, just to have more leads. But what we found is just having that open communication, touching base. It doesn't even have to be a formal sit down to just say, hey, is that working? Did that work? Or if I hear them on the phone, I'll say, oh, would you mind trying to say whatever? And I'll write up a script or that I am good at. Like I'll write up like what I think we should be saying. If we want to triage anything, colds, bladder infections, those kind of things, there's a little bit of prompts that they can look for. And when we started, we had also printed out there's a PA DPC docs, and there's a lot of the documents that have been put online and just says, oh, here, you can print this out and use this as a script. So we did use some other preformed scripts, especially as my mom and my sister, they hadn't done healthcare in a while. So it was just nice for them to have that, oh, well, hold on, let me see, and have a little script to read on the phone. And then you just kind of learned over time. But then now I'm noticing that sometimes my patients are getting scheduled and they don't have addresses in there. So then I can't write a prescription because there's no address to tell the EMR who the person is. So you do have to go back every couple months to say, hey, did we forget any of our workflows? Hey, how do we kind of keep this up? And I think just having team meetings is really important. So yes, we thought we got away from team meetings from when we left corporate, but there is some value still to just sitting down with your group of people, take them out to lunch, go over whatever you need to go over, just really making sure everybody's still happy.
Love it. Now, when it comes to your community, I will never forget this, how across the street they're growing cows. And then on the other side, there's high-rise apartments. But as you have been present in your community, not only practicing across from the gas station that you had your first job at, but you are a member of your Chester County Chamber of Business and Commerce, as well as the Women's Business Connection. So can you tell us about how you got involved in those organizations and how have those affected your practice?
When I was in Florida, I was active in our county's Chamber of Commerce. The county I came from, I thought was big, but it's not as big as the one I moved to. So I've met some connections from the Chester County Chamber, but I didn't realize that in our area, there's 6 smaller chambers. So I think in hindsight, I should have got the one that was closer to me. So Chester County is huge, goes from Philadelphia to an hour and a half away. So it's really big. And I don't know that it's necessarily been the best fit for my small practice. I have had some interest from it. I happened to meet somebody who works right across the street at one of our commerce meetings, but that's really been my only feedback. A lot of the events are farther away. They're all about an hour to 45 minutes away. So I'm like, that's not really my community. These people aren't really going to come to my practice. But I did find that there's a closer chamber that I have a friend who's in, and they're like, oh, this has been very beneficial for me. There's 3 other DPCs in the area. So I have had the benefit of talking with them as well. And there's an older doc who's been doing somewhat similar to DPC since the early 2000s. So he's been great. He doesn't feel threatened by me. I don't think the other ones feel threatened by me either. We all do it a little differently. Like, one, I'm a girl, they're 3 dudes. So some people I have one family that the husband goes to one of the other docs and the wife comes to me. And I just think that's kind of funny, but I'm like, that's great. That's great, because they found what they needed. And there's one of them is a little more holistic. The other one likes to do a little bit more mental health and geriatrics. So I think, and the other one is also a lot of sports med. I kind of do a little bit of everything. I love sports med. I've always done like high level sports and things like that. So I think after talking with all the other docs in this area and really trying to network with them, and my next goal for next year is going to be to get us together a little bit more so we could be a little more cohesive, a little more powerful, but is just use the smaller chambers. I just didn't know they existed. So I guess that's the other advice is don't send hundreds of dollars out the door and have it not be right, but you live and learn. So I got one connection from it, which if they sign their family up, then that'll pay for my chamber enrollment. So, and then I think this year I'm going to go for the Exton Chamber, which is just a smaller, more related to my community. But my biggest bang for my buck, and as far as just overall support, not even as far as financial, is just the Women in Business Committee. I went to Rosemont College, which is an all-women's college. So I love that. And I grew up with 3 sisters. So I'm all about the sisterhood. And I'm still friends with my college roommates. And I love the idea of women building each other up. And I don't think you always see that in medicine, because sometimes at the higher levels of leadership, we're more competitors for each other. Whereas, well, I'm used to being the only woman at the podium. Now there's this other woman at the podium and I'm no longer unique. Instead of saying, oh my gosh, there's so much room at this podium. There's so much room at the top. And instead of it being all of our, I don't want to be making men versus women, but instead of it being all older white men, maybe we could all be like, we could have a redhead, we could have a brunette, we could have someone with Filipino background. We could all really accentuate each other and still bring something different other than we're just women. Because my version of being a woman is very different than anyone else's experience as being a woman. So I just really like up my Women in Business committee. And they do a lot of volunteer stuff, and they pick a community organization to support with their donations per month. So I really like that idea of giving back to my community, being involved with my community, and it just gives me more of a sense of purpose. And there's some good friendships that I've developed in that group. Even if people don't come to me and give me their money, they still see me as a trusted advisor.
Thank you so much for sharing your journey today, Dr. Capoocia, and best of luck going forward into your second year of DPC.
Thank you. I'm so excited. It's an amazing journey. And I'm just so grateful for the direct primary care community out there who's really just said, you can make it. And if you're struggling, call us. I just think that's an amazing concept in medicine.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.